Hello, good afternoon. Today I would like to talk to you about my PhD topic, which is about the role of immunomodulatory strategies to improve outcomes in sepsis. My name is Júlia Hollósi, and I am a fifth-year medical student and a first-year PhD student here at Semmelweis University. My vision is standardized treatments for specific medical situations, and my mission is to delineate the best treatments and incorporate new technologies into care plans. I would like to do this through my specific goals, which are my two projects, which I started in the fall of this year. So my first project is investigating the safety and effectiveness of intravenous immunoglobulin treatment versus blood purification in septic patients. And it will be done as a systematic review and a network meta-analysis. So what's the problem? The problem is that sepsis is prevalent and deadly in the ICU. Around 30% of patients in the ICU have sepsis, and unfortunately around 26% of them die. So what do we already know? We know that intravenous immunoglobulins, IVIG, and blood purification treatments, such as plasmapheresis and hemoadsorption, may improve outcomes. And we know that a recent study suggested that plasma exchange and polymyxin B hemoperfusion may reduce mortality. So what's missing? There's no clear evidence on patient-specific outcomes, such as organ dysfunction. There's not really information about these treatments comparing to each other. The data is inconsistent, and the guidelines in general are indecisive. So our aim is to investigate which treatment has the most beneficial effect on organ dysfunction and sepsis. So for a bit more background on what these treatments are, in sepsis, there is a dysregulated host immune response to bacterial endotoxins, which leads to a cytokine storm and an immunoglobulin deficiency due to an increased consumption and decreased production of immunoglobulins. This eventually leads to septic shock. So polymyxin B adsorption is a blood filtration technique which involves the removal of gram-negative endotoxins. Plasmapheresis and hemoadsorption are similar. Plasmapheresis involves the removal of coagulation factors, immunoglobulins, cytokines, and toxins. And hemoadsorption involves the removal of cytokines and toxins from the blood. So these are all good at removing inflammatory factors from the bloodstream, but they don't really do anything about the immunoglobulin deficiency, which is why we think that there's a potential for intravenous immunoglobulins to help clear pathogens and toxins and interact with the innate immune system. Our clinical question is which immunomodulatory therapy ranks the best in improving organ function in septic patients? Our population is septic patients, and we have multiple interventions: IVIG treatment, plasmapheresis, hemoadsorption, and polymyxin B adsorption. Our comparator is standard therapy without any of these therapies, and our outcomes are organ dysfunction via SOFA score and mortality. Our hypothesis is that immunomodulatory therapies are superior to standard therapy in improving organ function in septic patients. Our clinical implication is that we would like to improve organ dysfunction and damage in septic patients. Here you can see our systematic search, which was done in 3 databases. And here you can see that we started with originally around 4,000 records, which after title and abstract selection and full text selection, we ended up with 77. And here you can see that we are currently in the data extraction phase. So let's discuss the articles that we have for this first project in a bit more detail. Of these 77 articles, 33 are about IVIG, 6 are about plasmapheresis, 15 are about hemoadsorption, and 23 are about polymyxin B. 76 of these articles have either mortality or organ score data. 74 of the articles have mortality data. And of those, 51 have data for 28-day mortality, and 23 have data for a mortality of different length of time. This varies between 7 days to several months. And then we have 29 articles which have organ dysfunction score data. Now, of these articles, 25 have SOFA score data, 3 have MOD score data, and 1 has both. So MODS is a similar organ dysfunction score data, but this brought the question to us, how do we know if we can pool the articles that have SOFA score and MOD score? So here you can see actually the components of the SOFA and the MOD score, and what you can see is that the categories are the same, and for the most part, the calculations for the categories are also really similar. The only difference is in the cardiovascular component, which has a pretty different calculation. So luckily, we are not the first people to have this question, and in 2002, this article was published which compared the MOD score to the SOFA score, and what they found was that even though you can't compare directly the SOFA score to the MOD score, you can compare the change in SOFA score to the change in the MOD score. And actually what we saw with the one article that has the SOFA and the MOD score is that this held to be true, that even though you can see the difference, you can see also that the change in SOFA and the change in MODs for both was the same, which means that all of these articles are poolable. Now let's talk about my second project, which is about investigating the safety and effectiveness of intravenous immunoglobulin therapy before and after the onset of septic shock. So what is the difference between sepsis and septic shock? Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. At this point, there's increased consumption and decreased production of immunoglobulins, leading to immunoparalysis. Septic shock is the last stage of sepsis with profound circulatory and cellular abnormalities which require vasopressor therapy after adequate fluid resuscitation. And at this point, there's a complete dysregulation of the systems, and it's very difficult to reverse. So as previously discussed, around 30% of patients in the ICU have sepsis, and around 26% of them die. Unfortunately, around 10% of them progress to septic shock, and at that point, the mortality becomes 46%, which is very high and which we would like to improve on, which is why we have this idea that IVIG could potentially replenish depleted immunoglobulin stores, a depletion which happens even faster in septic shock. This treatment does have promise, as a recent meta-analysis showed that IVIG reduced mortality rate in septic adults by 14%. However, the evidence is unclear on the best way to use it, and we don't want to waste it because there's many problems with that, such as it's very expensive and it's not very available. So we don't really have a good idea on what the cost-benefit ratio is. Therefore, our clinical question is IVIG treatment for sepsis more effective before or after the onset of septic shock? Our population is again septic patients, and now our interventions are IVIG treatment before and after the onset of septic shock. Our comparators again standard medical therapy without IVIG treatment, and our outcomes are organ dysfunction and mortality. Our hypothesis is that IVIG treatment is more effective in patients who receive it before the onset of septic shock. Our clinical implication is that we would like to improve patient survival and optimize resource management. Now, the other problem here is that the definition of sepsis versus septic shock has not always been constant. In 1991, according to the Sepsis 1 guidelines, there were 3 categories: sepsis, severe sepsis, and septic shock. This guideline was updated in 2001 to the Sepsis 2 definition, and then in 2016 to the Sepsis 3 definition, which is based on a different scoring system and only has 2 categories, sepsis versus septic shock. So in order to ensure that we are comparing apples with apples and oranges with oranges, we would like to do a subgroup analysis. In conclusion, these are my 2 projects, and I would like to be done with them in the fall of next year. And I would like to leave you with a quote that I think really explains how rare and precious and potentially valuable IVIG treatment is, which is that no one thinks about how much blood it costs. Thank you for your attention.
How are you planning to predict who will be septic shock in septic shock? So you mean to use IVIG preemptively, and
yes.
What kind of predictors are you using? Only the SOFA scores, or
Yes, and most of the studies, well, they had either patients who, like, they separated the patients who are already in septic shock and the patients who were just septic, and then they randomized there, but there was no specific protocol as to which patients they think would become septic. It's just either before or after.
Regarding the different interventions you mentioned in the treatment of septic shock, so is there any difference the length of these interventions in terms of the time frame?
Most of the studies had like a similar length, like a few days.
I mean, intravenous immunoglobulin, for example, 72 hours or shorter or longer. Hemadsorption, 72 hours, shorter, longer. So
there's a difference usually between like the length of, because intravenous immunoglobulin, most of the studies either only gave it once or they gave it like 2 times. So there was like two doses basically. And for the hemadsorption and the plasmapheresis, it was usually for a few days. So there's a difference between that. But for each category, they stayed pretty consistent, like the protocols.
In your second project, as I understood, you are comparing the immunoglobulin therapy before and after treating the septic shock, right? And your outcome is the mortality and the organ dysfunction. What about the side effects of immunoglobulin therapy? Because they do cause some problem in organs. How it will affect the results, what you are expecting from all these studies, like renal dysfunction or the hyperviscosity syndrome, which can cause by immunoglobulins?
From the studies that I have read, there were not really significant side effects listed for any of the situations.
Okay, thank you.